the first study that's ongoing, of course, is FOURIER, and this is in a wide spectrum of very high and high-risk patients, all of whom have incident disease and have undergone an event, but they may be at some distance from their earlier event. There are some particularly interesting subgroups of patients, notably peripheral arterial disease, notably stroke, notably diabetes. So FOURIER will bring us, hopefully at ACC in 2017, particularly critical information on what additional LDL lowering over and above a statin can bring us in terms of the reduction in events. Now, in contrast to FOURIER, the Odyssey outcomes trial is really focused on patients who have undergone acute coronary syndrome and who were recruited within a period of about a month after the event up to the year afterwards. So we'll have information in a separate group of patients. There may be a small degree of overlap with FOURIER, but nonetheless we'll have a very substantial database, which will of course ultimately extend the potential clinical application of this new class of agent. Essentially, the patients in both of the outcome studies were at a baseline LDL cholesterol between 90 and 95 milligrams per deciliter. So if we then impose about a 50 to 60% reduction in LDL cholesterol levels, of course, we're getting down to about 40 or perhaps even less milligrams per deciliter on treatment. Now the question is, what might the relative risk reduction and ultimately absolute risk reduction be under those circumstances? Now we know from the cholesterol trialists' regression line, this is taking a meta-analysis, if you will, of the intervention trials with statins, the suggestion is that about 40 milligram per deciliter or 1 millimolar reduction in LDL cholesterol translates into between a 20 and 25% reduction in relative risk for cardiovascular events. Now, if that's the case, that will take us in these two outcome trials to slightly more than a 20% relative risk reduction. And of course, we would hope that that would certainly be attained, and that there may even be a slightly greater benefit that might result from perhaps a synergy in the mechanisms implicated in a combination of statin and PCSK9 therapy. We don't know that. It's a point of speculation. But it's possible that, as we saw in GLAGOF, when we can have additional regression, which implies plaque stabilization on top of a statin, and therefore, in my mind, there may be a greater degree of benefit because we're going further, if you will, with regression and potentially plaque stability in these trials than we have done before. And GLAGOF supports that possible interpretation.